Please listen carefully.
Hello and welcome to GasGasGas, your one-stop podcast for the FRCA primary exam. This podcast will fill your brain with information. Listen to it, think about it, and check out the show notes on the website. There you will find the core diagrams you need to be able to draw and describe for the exam. This podcast can squeeze into your day. Listen while you're driving to work, cooking dinner, maybe when you're on call, or in the gym. Eventually the revision is going to end. But for now, expect facts, concepts, model answers, and the odd tangent. Remember to rate and follow the show to hear much more. Hello everyone, it's James here at GasGasGas. Today we're going to talk about Propofol. It is the most commonly used anaesthetic induction agent in the UK. You find its use in induction in theatres, sedation in A&E resus, maintaining sedation in ITU patients, very commonly. You will be already, or very soon to be, familiar with it, but today's focus, as always, is on the exam, and odds are someone's going to ask you about Propofol, or there might be the odd question on Propofol. We've already covered a podcast on rocuronium, where there was an introduction to how to go about learning the information required for these drugs in a structured manner, and also then how to perhaps begin delivering it in an exam. There's a strong chance you might start your spiel, get to a certain point, and they catch you and say, tell me more about the distribution profile of Propofol in TCI. And then you might take a different tangent. But it's generally a good idea for all the core drugs to learn this here spiel so that you have a solid grounding in the information about the drugs. And therefore, you could go about applying this information in a multitude of different manners throughout your career. They don't just want someone who can verbatim regurgitate information, but also understand why certain things are relevant in certain drugs in their utilisation day to day. So getting on with it, when you're giving a model answer to a tell us about so-and-so the drug, there's an approach that you'll be able to see on the show notes for this podcast. But broadly speaking, you name it, you define its class. If it's got a particular chemical name, you can throw that out there. For Propofol, that'll be your 2,6-diisopropylphenol. I'm pretty sure there was a question, either I think in one of the question banks or in one of the books, it wasn't in my exam, which was, tell us about the pKa, or what is the pKa of 2,6-diisopropylphenol, knowing that you wouldn't have a Scooby-Doo unless you knew that Propofol's other name. So it is worth knowing, especially for the very, very commonly used drugs, because they expect a high degree of knowledge. They're not going to ask you about vecuronium in quite the same detail, because that'd be mad. So we'd go name, class, chemical name, and then the colour and appearance. So this is a clear colourless solution, or this is a white liquid that comes in ampules of 20 ml at 1% concentration. What additives might be found, or how it's presented. So, thio's in that nitrogenous atmosphere. Propofol has egg phosphatide and soybean, so you would say important additives to know are blah. And then if it comes in multiple concentrations, demonstrating that there could be some 2% Propofol, and you certainly wouldn't want to mix that up with 1%. You find yourself in a lot of bother. There may be some particular numbers relevant, more so for your volatiles, like what the MAC is, what the blood gas and oil gas coefficients might be, what the boiling point and saturated vapour pressure might be. Good luck! And then dose route, so is it IV, is it transdermal, can you shoot it up someone's nose, is it intramuscular? And then a general dosage range is a worthwhile thing to be able to say about it as well. 1 to 2 milligrams per kilo in Propofol, for example, depending on the age and shape, etc. of your patient. Then you're going to want to continue this structured approach and talk about the pharmacokinetics and the pharmacodynamics. So remembering that kinetics are absorption, distribution, metabolism and elimination. And the dynamics being how it works, what actions how it works, and what effects it will have on a person. The onset and offset times for the effects of the drug to take place, and then side effects of the drug. You should subdivide side effects into cardiovascular, respiratory, GI, neuro, metabolic, for drugs that have a broad range of side effects. So you don't forget stuff and that you look structured. If you get asked about a drug in an exam and you start doing all that, you'll be alright. They won't just want you to vomit information though. It'll be, tell us about a drug, and then they'll ask you, well, okay, so talk me through how anticholinesterase are used to reverse neuromuscular blockade. Why don't we always use Sugamidex? Something like that. So we're going to get on with the model answer now. So I'm going to vomit this model answer at you. It's worth listening to just because you're going to pick up some information. I'm not doing this from memory, I've got it written in front of me, so don't stress about that, you will develop these skills. So, Doctor, tell me about Propofol. Propofol is a phenol derivative. Its chemical name, 2,6-diisopropylphenol, is a commonly used anaesthetic induction agent. Its appearance is of a white opaque liquid, presented in 20, 50ml or 100ml ampules or bottles, a concentration of 1 or 2%. Additives of note are egg phosphatide and soybean oil, although these aren't often terribly implicated in allergy in patients. It is an intravenous drug, dosed at 1 to 2 milligrams per kilo, sometimes more if they are very large or alcoholic, aiming for a plasma concentration of like 4 to 8 mics per ml. That will maintain anaesthesia during an operation, more relevant in TIVA. Considering the pharmacodynamics of Propofol, its mechanism, it likely potentiates endogenous GABA. The true mechanism of action of how it induces hypnosis is not entirely elucidated. Its actions are hypnosis that is dose dependent. It also is a useful antiepileptic in status epilepticus when inducing anaesthesia. Its onset time is greater than one-arm brain circulation, about 30 to 40 seconds. Offset is dependent on infusion time. A bolus dose redistributes quite quickly, offsets within 10 minutes or so. Larger doses or prolonged infusions are going to take longer to wear off. There are some important side effects to consider with Propofol. Cardiovascularly, it inhibits sympathetic activity, leading to a drop in venous tone, i.e. less preload, a drop in arterial tone, leading to less systemic vascular resistance. Cardiac output is somewhat preserved, but these changes lead to a drop in perfusion pressure across the system. Cardiac output is relatively preserved. It is also a myocardial negative inotrope, but not very much. From a respiratory perspective, Propofol causes an apnea. It also will obtund laryngeal reflexes, highly useful in citing LMAs, and causes a degree of bronchodilation. Its CNS effects naturally induces hypnosis. Looking at it from a physiology perspective, it reduces cerebral oxygen demand, it leads to a reduction in intracranial and intraocular pressure. Some patients, about 10% of them, have paradoxical excitatory movements at induction. This is likely due to inhibition of inhibitory structures within the brain. Just for you guys, I like to think that the drug doesn't get to all parts of the brain equally, and also some parts of the brain are more susceptible than other parts. You've probably seen them get a bit stiff, looking straight up at you, been a bit freaked out that the patient's looking at you when they should be falling asleep with Propofol. And you could also think about it as it's like the excitatory phase of a gas induction. They're not quite deep enough that you've anaesthetised all of their brain, so they get a bit wriggly and disinhibited. Anyhow, moving on. Metabolic effects. Continual infusions of high-dose Propofol leads to Propofol infusion syndrome. This is classified with high triglycerides, a metabolic acidosis, arrhythmias, rhabdomyolysis, and renal failure, and it's fairly bad news. Other things of note is it does sting on injection. This can be countered with some lidocaine or the use of a larger vein. From a pharmacokinetic perspective, it's not an orally administered drug, so I'm not concerned about absorption. From a distribution perspective, it's got a high volume of distribution relative to other induction agents at 4 litres per kilo. It is 98% protein bound, again the highest of all the induction agents, and a pKa of 11, the highest of all induction agents, leading to it being 98% unionized at a pH of 7.4, which is very conveniently going to mean that there's a lot of agent available to cross membranes and have positive effects leading to hypnosis. Its lipid solubility does, however, mean that it's going to rapidly redistribute to other organ systems and tissues, hence why actually the offset time of a single bolus is quite short. From a metabolic perspective, the half-life ranges from 9.3 to 60 minutes and is quite context sensitive. It's metabolized by the liver. 40% is conjugated to a glucuronide, 60% is metabolized to quinol, which then gets sulfated and excreted in the urine. The clearance, though, does exceed hepatic blood flow, and this suggests that there's some extrahepatic metabolism also occurring alongside. Its clearance could be considered as a range between 18 to 40 mils per kilo per minute. The key things to tell you when we're using Propofol is that in sick people it is remarkably good at dropping blood pressure, and you'd be rather mad to be using it as an induction agent in someone who's awake, who needs to be asleep, when their blood pressure is crap, because the sufficient amount to get them off to sleep is probably a dangerous amount if they've got low blood pressure. Other drugs like ketamine, you could talk about etomidate, but nobody uses it, or taking a very midazolam, fentanyl heavy whiff of propofol approach would be safer than a standard fentanyl night-night sort of picture. It can also be used for brief sedation with boluses, TCI sedation, which is probably actually easier to manage than to bolus it. If you're doing a cardioversion, just use a bit of propofol. I tend to give 10 to 20 milligram aliquots and give it plenty of time to cook because they're probably an AF. Expecting a dose range depending on how frail the patient is from like 40 to 100 milligrams of propofol to achieve enough sedation that they stop responding to voice, then you zap them. So the examiners then might say, "You mentioned PKA. Could you explain this in further detail for us, and in what other drugs it might bear relevance to function?" And you go, "Oh God, yeah, all right." So I'm going to tell you that PKA is a way of putting a number on the sort of water-lipid dissociation coefficient relative to the pH of a system. Don't forget to also consider the pure definition of PKA, which is that number relates to the pH at which the agent in question is in a 50-50 ionised, unionised state. So with propofol, the PKA is 11, which is far away from a physiological pH. And at PKA, if you were to take that propofol and put it into a liquid that had a pH of 11, 50% of that propofol would be unionised and 50% of it would be ionised. The ionised element is kind of useless from a pharmacological perspective. Can't do anything when it's ionised because it won't cross membranes because they're negatively charged. This is why PKA is relevant, because as you can imagine, if you have a larger fraction of unionised agent lurking in the plasma trying to get to its effect site, it's going to get there quicker. So taking that propofol with a PKA of 11, which is the highest PKA of the induction agent, and putting it at a pH of 7.4, 98% of it is unionised, so there's a huge amount of molecule that is quite highly lipid soluble now, wants to get across those membranes, is going to get where it needs to go. This is also a way to think about how other drugs work, and it is relevant to many other drugs. The opiates, it's very important to learn the PKAs of them, as well as your local anaesthetic agents, which have varying PKAs that lead to varying amount of agent available to cross that membrane in your neurons and influence those sodium channels. PKA is one of the direct influences of onset time. The more unionised, the faster the onset. So I remember my very first day of anaesthesia. I was with an anaesthetist who just handed me some drugs and went, "Go on then." Obviously, that on reflection was ridiculous, but we got on with it, and I gave a 1.8 milligram per kilo dose or so to the patient. Nowadays, I don't think about the dose more than I look at the shape of the patient, the age of the patient, their alcohol consumption or other illicit drug use, how anxious they are, how half asleep they are if it's a fractured neck of femur patient who's already hypoactive, delirious, and use all these things to weigh up the dose I'm going to give. It's always better to start with a small amount and work your way up. You don't want to find yourself in limbo where a patient's flailing and a bit disinhibited but not actually anaesthetised, although that's quite a rare situation. It's much better than finding yourself with a systolic that's 50 and having to do something stupid like CPR or give adrenaline because you're a bit heavy-handed. Propofol is really synergistic with other drugs, especially if you let those other drugs cook sufficiently, i.e. fentanyl and midazolam. If you get them in and let them bake for at least 5 minutes, then the induction dose of propofol is markedly reduced. The other thing I want to make you aware of, although you're going to need to read and learn about it or listen to a future podcast, is the pharmacokinetics of a target-controlled infusion of propofol. These use models to understand how big the wet bit, how big the fatty bit, how big the effect site bit, and the muscly bit of a patient might be, and then work out how the propofol shifts between all these different pots to try and project a plasma and subsequently an effect site concentration to keep someone asleep with a propofol. It's quite a long topic, so we're going to do it later. But also bear in mind that there is a bit of a back of a napkin TCI formula where you give 10 milligrams a kilo for 10 minutes, 8 milligrams per kilo for another 10 minutes, and then render a continuous effusion at 6 milligrams per kilo per hour, all of those things, and titrate to, how regularly the patient is. So that is Propofol with GasGasGas. My name's James. Thank you very much for listening. I hope you can go on to think about Propofol and anaesthetise a range of kiddies to grannies today. Enjoy. If you found it useful or awful, please like and subscribe and rate the show. Definitely check out the show notes for those diagrams and the detail of this content. It is a bucket of content to get to grips with. Keep working at it, and you will get better, faster, and stronger. It is vital to keep your interest alive for the science that we're covering and not overcook yourself. You will be amazed by what you know come exam day. Don't freak out. Keep studying.